Dear Chairperson, thank you for invitation to EBC 2021. I'm Yoshi MURASATO from Kyushu Medical Center in Japan. My topic is the feasibility and efficacy of the ultrashort side branch dedicated balloon in coronary bifurcation stenting. It is my disclosure slide. Port and side branch dilation has been reported its superiority over final kissing balloon inflation in terms of less overstretch like overshape, less stent obstruction in the side branch ostium, and less malapposition in the bench testing. However, the side branch dilation with the long balloon has a risk of stent deformation indicated in this slide, so we propose using a short balloon, ultra short balloon, for the dedicated for the side branch glider balloon. We usually use the 4 mm length balloon. This is unique for the side branch direction, and this balloon has a truckable for the reorientation of the tip of wave from the obstacle, optimal side branch ostium expansion without damaging this side branch, and minimize the member stent deformation. This is a bench testing to compare the conventional sideways dilation by a long balloon and that by a short balloon. In the conventional sideways dilation, guide wire deviation to the inner side at the side branch ostium is maintained during balloon inflation, and stent deformation in the opposite side of the side branch is likely to occur due to balloon straightening. Side branch dissection and stent malapposition at the cardinal side are also likely to occur. On the contrary, side branch dilation with a short balloon could correct the guide wire deviation and provide optimal side branch osseous size dilation with less stent deformation and side branch injury. This is a test for overdilation of the balloon dilated at 14 atmosphere in the hard stentic region. Either 4 or 6 mm balloon did not show the dilation over the compliance curve, while overdilation, so-called dog form phenomenon, occurred in the long balloon. It suggests short balloon is superior to long balloon for sufficient side branch ostial expansion and less injury. Recently, our study concerning the side branch dedicated ultrashort balloon, glider balloon, has been published in the Euro Intervention. This is a single center prospective observational study. We enrolled the 194 patients in the 207 regions, and the average age is 70 years old, and the higher prevalence of the male gender hypertension dyslipidemia in 80%, and diabetic mellitus is also frequently observed, 40%, and acute coronary syndrome also enrolled in the higher frequency at 22%. In terms of region background, the left main included in the 42%, and a true bifurcation region was presented in the 46%. In terms of a procedure, average stent size of 3.1 mm, and the glider balloon size is relatively larger, 2.7 mm. Pot or pot-like inflation was performed in the 85%. The size of the balloon is 3.6 mm. And the final side branch dilation, glider balloon alone is 92%. And all procedure guided by the IBUS or OCT or OFDI. This is the imaging analysis immediately after glider balloon dilation. In terms of malapposition, it occurred more frequently in the side branch side and presented side branch opposite side only in 3.4% of the cases. Stent deformation at the bifurcation was observed only in the side branch side. Stent under expansion and malapposition remained in the proximal member cell in 13%, which required an additional procedure. Glider balloon crossing failure was observed in 8.7%, But secondary failure after small balloon dilation was found only in 2.4%. Cerebral stenting due to the dissection occurred in 1.4%. Stent deformation due to glider balloon dilation was found in 5.8%. Of them, correction by Lippert was performed in 2.4%. Free from additional procedure due to the failure induced by glider balloon dilation was found in 92.8%. The additional procedure in the non-bifurcation site was performed in 24.6%. Finally, 68.1% was free from any additional procedure after glider balloon dilation. In 85% of the case, we obtained the follow-up CAG at 1 year. QCA results show that proximal member cell, distal member cell, it remains a lower value in the follow-up period. And also in the side branch, here you can see the 30% diameter stenosis remained at the follow-up period. This is a clinical outcome at 1 year follow-up. Target region revascularization, 7.2%, cardiac death, 2.1%, myocardial infarction, 2.1%, stent thrombosis, 1.0%. So major adverse cardiac event, including them, showed a 10.3%, which are acceptable for the bifurcation region. Ladies and gentlemen, this is my conclusion slide. Advantage of ultrashort balloon for sideband dilation is the following. Less member stent deformation, avoid proximal member cell overdilation, preserved round and uniform member stent dilation, and less sideband injury. Combination with pot plus sideband with ultrashort balloon in the clinical study demonstrated that acceptable acute and chronic result, and the report is not necessary in 70% of the cases. Thank you for your attention.